Alright, we're going to go ahead and start this lecture. This is chapter 6A only. We're not going to get into part B, which is the new coding that hasn't quite started yet. So let's look on page 145 to begin with. The ICD-9 stands for the International Classification of Diseases, and then it's the 9th edition, and then the CM stands for Clinical Modifications. So the ICD-9, I know we've talked here and there about, but basically this is where you're going to look to code your diagnoses that the physician gives the patient. And there's 3 volumes of the ICD-9 book. And you have volume 1, which is called the tabular or the tabular list. You have volume 2, which is the index to diseases, and then volume 3, which is like procedures and services, which we're not going to use. We may use like once or twice, but we're really not going to even delve into that. We're mainly going to only use volumes 1 and 2, but I do want you to know that there are 3 volumes. The tabular is like a numerical order of diseases, but what you have to do when you code is you have to go to volume 2, which is the index to diseases, to look up the term. Let's say we have depression, you'll look in the D's for depression, and then you'll code from there. And then you check, once you find the alphabetical order in the index to diseases, it'll be given a number like 123.4, and then you go to the tabular in numerical order to verify and make sure that that's the disease. So that's kind of the very basics on coding. Look at mandatory reporting of ICD-9 codes. The very first people to do this was actually Medicare. It was actually Medicare and Medicaid. The government did it to better handle the claims, and then basically from there all these other insurance companies picked it up, and that's why we do it today. So the Medicare catastrophic coverage of 1988 mandated the reporting of claims, and then like I just said, every other insurance kind of came up from there. These, let's say, the codes are there to show medical necessity, and like we did in the last chapter where we linked the diagnosis to a procedure. So if we have headache and we do something like a chest x-ray, it doesn't link, and that does not show medical necessity. So that's why we do it for that. An injury, that's one of your key terms, and I'm sure you all know what an injury is, so I'm not going to tell you the definition. But that also will show medical necessity. If we do have an injury like related to work or whatever, that will really help show medical necessity to see what can be reimbursed. The employer has to reimburse basically the charges from the physician, or they have to pay directly. So let's look at an example. Before we get there, sometimes if a patient does, like especially Medicare and Medicaid patients, if they don't if they do something that is not medical necessity, that's not a medical necessity and doesn't link appropriately, they sign what's called Advance Beneficiary Notice, or ABN, and this basically just says that they agree to pay what the insurance doesn't pay. So let's say they want to have like a knee replacement, and maybe Medicare says, well, you haven't really been complaining of knee pain, you haven't tried this procedure or this procedure, but the patient just really wants to have that knee replacement. They have to sign that Advance Beneficiary Notice saying that they agree to pay the difference of what Medicare doesn't pay. So make sure you remember that. So let's look at an example at the bottom of page 145. It has a patient with insulin-dependent diabetes. They're treated in the office for leg injury sustained in a fall. And then when the physician questions the patient about his general health status since the last visit, the patient admits to knowing that a person on insulin should perform a daily blood sugar check. The patient also admits to usually skipping this check 1 or 2 times a week, and he's not performed his check today. Physician orders an x-ray of the leg, which proves to be positive for a fracture, and a test of the patient's blood glucose level. So basically, if this only stated diagnosis was a fractured tibia, that doesn't show medical necessity. The blood glucose test wouldn't be covered, basically, and it'd be rejected for payment. So that's a good example of what can happen if you're not extremely careful. Let's look at ICD-9 updates. You do need to know that these are updated annually. And ICD-10 will be coming out next year, and I'm pretty sure it will be updated annually as well. But if we use outdated codes, then we can end up having to pay because of denied claims. So it's really imperative that we use up-to-date codes. Now I know in the coding books that you're going to have, some of them are from the early 2000s, which is fine because we're practicing, and it's going to be the same thing as in a current book. I mean, it's the same way, except they may just have different codes in them, but at least you get to practice looking them up. And some of them may stay the same, and some of them may change by like one digit. It just depends. But they are changed. They are updated annually. In Encoder, we also have this software. This is really neat. Of course, it's not always correct, but an Encoder basically is where you can go into medical software and type in a diagnosis, and it gives you the code that goes with it. And now sometimes it may be exactly right, and sometimes it's not exactly right. You have to double check. So that's where the medical coder, they would actually double check to make sure that's correct, because a lot of times it may need to be more specific than what the Encoder software gives you. And then we have a computer assisted coding, the CAC. This is basically where it does it automatically. It can read the physician's notes and assign the diagnoses and the diagnosis codes automatically. And of course, you still need a medical coding expert or an MA or whoever to be there and verify those codes to make sure they're accurate, because you know, humans make mistakes, computers definitely make mistakes as well. So the next section is medical necessity, and we have already talked about that. And medical necessity basically is the measure of whether a healthcare procedure or service is appropriate for the diagnosis and or the treatment of a condition. Okay, so make sure you remember that, because we'll be talking about medical necessity quite a bit. Let's look at the documentation guidelines on bottom of page 147. We have the purpose. We want to see the purpose of the procedure. You know, why are we doing this procedure? The scope of the procedure, the most appropriate level of services provided, taking into consideration potential benefit and harm to the patient. The doctor needs to show evidence, which is, shows, that you've tried this one thing and it maybe didn't work or didn't work as well. So you're trying to basically improve health outcomes. And then the doctor needs to show value as well, to show that the treatment is cost effective. Now, if I have a hurt knee and the doctor doesn't even want to do an x-ray of it, he goes straight to MRI, then insurance is probably going to deny the MRI because they want an x-ray first. So that's the kind of value that I'm talking about. Alright, let's flip to page 148 and talk about outpatient ICD-9 coding. Outpatient can be like an outpatient clinic or a physician's office, or it can be talking about outpatient surgery or something like that. But basically, I want you to know all the different organizations that kind of give us the coding guidelines. So we have the American Hospital Association, or the AHA, and we have the AHIMA. It's called the American Health Information Management Association, and that's called AHIMA. Then CMS, the Centers for Medicare and Medicaid Services, and then the NCHS, the National Center for Health Statistics. All four of these places will give guidelines of how things should be coded. Let's look at this coding tip. Begin the search for the correct code by referring to the index of diseases. Never begin searching for a code in the tabular list, because this will lead to coding errors. If you search in the tabular list, you'll be searching forever. So it's best to go alphabetically. As I said when we first started this chapter, and look the diagnosis up correctly then. Now, when we look at a diagnosis, some of them have, 2 words, 3 words, even more than that. And we have to figure out, what the main term is. So we're going to talk about, a first listed condition in main terms a little bit. And so let's pick up on 149 and look at the first listed condition. It's really important. Do you remember, if you can remember back to when we were playing on that MOS software, I told you that it was highly important that, if the patient had more than one diagnosis code, that you put it in order, A, B, C, and D. You can't just be in random order. And that's why a first listed diagnosis is considered the main reason the patient is coming in today. So let's say they're coming in for follow-up on diabetes, and then you figure out that they have a headache as well. But what did they come in for? They came in for diabetes. So diabetes would have to be first, headache would be the second. Okay, so that's what's considered the first listed condition or the first listed diagnosis, what they came in for today, the day that you're doing your coding. Now, in the hospital setting, it's called the principal diagnosis, and I want you to make sure you remember the difference in those. First listed diagnosis is in a outpatient setting, which is physician's office, and then your principal diagnosis is in the hospital. And this would be like the main reason a patient is coming to the hospital. If they have pneumonia, then that would be the principal diagnosis. So principal diagnosis is in the hospital, first listed diagnosis is in the physician's office. Let's see. Let's look at the coding tips. Outpatient surgery is when a patient presents for outpatient surgery. You want to code the reason for the surgery, okay? Because sometimes we may not know what's going on until after we do the surgery, but we code the reason for the surgery as the diagnosis. Even if the surgery is not performed due to like a contraindication or something, we still want to code the reason for the surgery. If a patient's having an observation stay in the hospital, we want to do the medical condition as the first listed diagnosis, okay? Or the principal diagnosis, I guess you could say. Outpatient surgery that requires observation. This is when a patient prevents for surgery and develops complications that require observation. So we want to code the reason for the surgery as your first diagnosis, and then you want to code the complication next, because they actually came in for surgery, but then later on they had a complication. So you got to code it by, I guess, as a chronological order, pretty much. And I'm sure you know what an inpatient is, but just to refresh your memory, inpatient is anyone that stays in the hospital for up to or over 24 hours. Or it can be considered a long-term facility too. So remember again, and the book tells you, principal diagnosis is the hospital, first listed diagnosis is like a physician office or outpatient facility. Okay. The principal diagnosis in the hospital is usually made after we know what the physician has had, okay? What the patient has had. So we may, bring in the patient because they've been vomiting like crazy. And then, that's what we're going to give them in the medical office, that they've had excessive vomiting. However, when we admit them to the hospital, they're not going to give them a diagnosis until maybe they figure out that they have H. pylori, and that's the reason why they're vomiting. So the principal diagnosis is always going to be made after you figure out what's going on with the patient. Then we have secondary diagnoses, and this would kind of be like the same example. Your first listed is what they're coming in for, and secondary is going to be anything else that was discussed, or if the doctor gave them any medicines because they have a certain other condition, then we have to code those next. A comorbidity is kind of like this. Comorbidity is a concurrent condition that coexists with the first listed diagnosis. Okay. Let's see. Look at page 150. Then we have a complication. This is when something goes wrong. with whatever condition or procedure that they're having currently. So it's a condition that develops after outpatient care has been provided. It gives you an example in the book. During the patient procedure, when they were in the office, they had sutures. They went home and they tore out or they ruptured. And so we would still, if they came back in and we just only said that the patient had ruptured sutures, that would make no sense. So we'd have to put, he had a laceration and then he had ruptured sutures, so we can make sure that it makes sense. It gives you an example here. A patient seeks care at the healthcare provider's office for an injury to the right leg. Upon x-ray in the office, is diagnosed as a fractured tibia. While in the office, the physician also reviews the current status and treatment of the patient's type 2 diabetes. So the first listed diagnosis is what they came in for. So that would be the fractured tibia, right? The secondary diagnosis would be the type 2 diabetes. Okay, so what diagnosis would link to the leg x-ray? Should be the fractured tibia or the leg pain. And then what justifies the office visit? Well, they came in for leg pain again. So that's just one example. We'll do some other examples in class. So let's look at Part B on page 151, the tabular list of diseases. Again, this is the numerical listing. All right, Part C, the accurate reporting of ICD-9 codes. The documentation from the physician has to be specific for you to be able to code correctly, basically. So you have to document the symptoms, problems, whatever the patient's going on. The physician has to document thoroughly. The sections of code 001.0 through 999.9. This is reasons. Infectious. It's the classification of diseases and injuries, and we'll talk more about this in class. Codes that describe signs and symptoms, again, we'll do examples in class. But these, if a patient comes in, we've done, they've got a sore throat, we've done a strep test, it's negative, we can't really figure it out, so we can't say, that he has strep throat because he doesn't, so we have to code sore throat. So if we don't have a diagnosis, we have to code the symptoms. Encounters for circumstances other than disease or injury, we have V codes. V codes, and we'll again do examples of these, but V codes are stuff like maybe I didn't come in for a disease or injury, but I came in for a physical exam. So a V code may be like a well woman checkup or a well male checkup. Or it could be like a family history of cervical carcinoma, something like that, something that affects the health status, but it's not an actual disease or diagnosis. Let's see. The level of detail in coding, you have to code to the highest specificity. Okay, now some codes will come in only 3 and they don't have any more digits after it because there's just nothing that goes with it. And then, but the highest a code can be is 5 digits, 3 digits before the period, 2 digits afterwards. And if we always want to attempt to code to the higher specificity, is that going to happen every time? Absolutely not. Depression, for instance, I believe that's only 462. I think it's only a 3-digit code, and we can't code any higher than that unless we have a specific diagnosis. So just remember, you always want to look for the most specific. Let's see. You have to be extremely careful too, because when you're looking, let's say you find depression and you see 462 or whatever the code is, and you're looking down, the information that here's depression, but some more information that goes along with depression is going to be tabbed underneath it. So you have to be extremely careful when you're looking at that to make sure that you are under the same diagnosis. And again, we'll practice with that. Alright, number H, or letter H, ICD-9 code for the diagnosis, condition, problem, or other reason. This is going to be let's see. This kind of goes back to what I was saying about, your secondary diagnosis, any kind of coexisting conditions that the physician may have covered that day, or that he may have refilled a medication on. If he did anything with it, we have to list it as a coexisting condition. If we have an uncertain diagnosis, this can happen, and we have to be very careful with the words. If the doctor says rule out fracture, that is a huge no-no. We cannot code a rule out, probable, what other words give you, working diagnosis, suspected, questionable. Those are no-no words. If the doctor gives you that and it says suspect or suspicious lesion or something like that, we have to code it differently. If they come in saying probable tibial fracture, we cannot do that. We can say leg pain. We could code like a fall or however they injured it, but we have to have a real diagnosis. And if we have anything that says rule out, questionable, that's not 100%, then you have to go to symptoms. You cannot code those. A qualified diagnosis is another one of your key terms, and this is a working diagnosis. It's not yet proven or established, and so if it's not proven or established, then we cannot give the patient that. Let's say I go in and I've had a history of high blood sugars, and the doctor is waiting on tests to check me for diabetes, but it hadn't come back yet. The doctor cannot diagnose me with diabetes. They have to diagnose me with high blood sugar or frequent high blood sugar, because giving me a disease that I don't have is a huge no-no. So that's a qualified diagnosis, is something that's a working diagnosis. So and those are the kind of things that we want to try to avoid coding. So look at examples. If the doctor says suspected pneumonia, you cannot do that. You've got to look for shortness of breath, wheezing, rales, rhonchi, whatever it is. Questionable Raynaud's. No, we got to go numbness of the hands. So you got to look for symptoms. Let's go to item J there. This is chronic diseases. These are chronic diseases that are always treated pretty much. They're treated on an ongoing basis, and usually if they were refilled, the medications related to it are discussed in any kind of way, then they have to be coded with every visit. Letter K, code all documented conditions that coexist. That's pretty much self-explanatory. If a patient has a history of something, let's say they come in and they're having abnormal periods, we do a pap smear. It shows, later on they come back and we find out they have cervical cancer, and maybe they have a history or a family history of cervical cancer. You're going to get more reimbursement if you put, the patient has abnormal pap smear, family history of cervical cancer. You're going to get the biopsy approved, the cryosurgery, the cervical ablation, whatever procedure needs to be done will be better approved if you use a history, anything to prove more that the patient has that condition. Patients that are receiving diagnostic services only, this is like when they come in just with a cold or something, or just with strep throat, or just with a headache, then and we don't touch any other condition, then that's all you have to do is just that one diagnosis. You don't want to code related signs and symptoms in addition. If we have a strong 100% diagnosis of strep, it came back positive, then all we have to code is strep. Don't code strep, sore throat, all that. The doctor may try to do that, but that does not affect reimbursement, and sometimes you can have it sent back because it's done incorrectly. Alright, letter M, patients receiving therapeutic services only. This is when it says they are only used during an encounter or visit sequence that It's first the diagnosis, condition or problem, or other reasons for the encounter, visit, and we've kind of already talked about. So if the patient's just coming in for a follow-up on diabetes, they don't have any other problems, then just code diabetes. Patients receiving pre-op evals. These we have to usually do like a V code for that, because we're not really performing, it's not for a disease, it's for a service basically, and so it's going to be a V code, and then after the V code we'd assign like another code for the reason for the surgery. Ambulatory surgery or outpatient surgery, we're gonna code why the surgery was performed. You know, if they have a broken foot, then it would be, you know, an ankle fracture or whatever. But whatever the reason the surgery was performed, that's what you code. Then post-operatively, what you can do, if the post-operative diagnosis is different, then you are going to use a post-operative diagnosis, okay? So make sure, remember, if a post-op diagnosis is different than the pre-op diagnosis, you always want to code the post-op diagnosis. Prenatal visits. These are usually a V code, like supervision of first trimester pregnancy, something like that. It's not really a disease or a condition, but it's a service that we're providing, supervision or prenatal care. I think there's a code for that too. So, but supervision of normal first pregnancy is a lot more specific than just plain prenatal care. Alright, let's turn to page 154. We've already talked about the 3 volumes. Then you see the ICD-9 tabular list in volume 1. You do not, and I repeat, you do not have to remember that long list of chapters. That's just an FYI that you can go back to if you wanted to you know, to help you out. But you do not have to memorize those, okay? So just remember that. Now, on top of page 155, the 4 appendices you do need to memorize. Appendix A is the morphology of neoplasms, or an M code. Appendix C, these are classification of drugs by the hospital formulary. Then Appendix D is a classification of industrial accidents. And Appendix E is a list of all the 3-digit categories. Okay, so I do want you to remember those appendices. Alright, let's go into V codes. V codes, like I already said, these are when you have a circumstance other than disease or injury, like a type of service, and it gives you examples: removal of a cast, exposure to tuberculosis, personal history of breast cancer, well baby check, annual physical. So those are all V codes, okay? And we're going to learn how to code those Wednesday. Then we have E codes, and these are located in the back. They're considered a supplementary classification, and they describe the external cause of an injury. So let's say I fell from a building and cracked my skull. That's where we're going to go to code it, is an E code. Now, the big thing about E codes is they are not reimbursable. So remember this: you cannot ever use an E code as your first listed code. Okay, you have to have a diagnosis and then an E code to show how it happened. Okay, so remember that with E codes, and we'll do some examples later on. The appendices we've already talked about. I do want you to know the appendices though. Flip on over to 156. Neoplasms. The ICD-9 has a table of neoplasms, and we have to look at the different terms, or the different terminology associated with neoplasms. The first one it gives you is the morphology. This indicates the tissue type of the neoplasm. Okay, then we have benign and malignant. Benign means it's non-cancerous. Malignant means that it's cancerous. So you need to remember the difference in those. If the patient comes in and we're just biopsying the lesion, we cannot code a neoplasm, we can't use the neoplasm table. We don't know if it's benign. We don't know if it's cancerous. We can just say it's abnormal. So we'd have to code it in the regular index to diseases. Then we go on to the mental disorders. This is not in there currently. Now in some of these books you may still find it, but I just wanted you to know that it's found in the regular index to diseases now. It doesn't have its own table. Then if you skip on down the bottom of page 156, and we will do all these examples in class. Let's see, the ICD-9 classification of drugs in Appendix C, which you need to know, is the formulary listing for hospitals, and it'll give you the code that's attached to it. So if the patient is given Rocephin, then you have a code that's attached to it that you will need to go look up the code so we can, charge the patient. Okay, excuse me. Let's look on page 157. Volume 2, the Index to Diseases, contains 3 sections. Your first section is the Index to diseases, and it's an alphabetical listing of pretty much every disease and condition you can ever think of. Then after the Index to diseases, we have the table of drugs and chemicals. You'll use all 3 of these little subsections frequently. The table of drugs and chemicals will go into more detail shortly, but basically if anybody was trying to commit suicide and swallowed a bottle of Tylenol, this is where you would go to do that. Then we have the index to external causes, or the E codes, and that would be after the table of drugs and chemicals. So make sure you remember those subsections within the index to diseases. Alright, let's flip over to page 158. We're going to, this kind of starts telling you about how it's kind of set up, basically. And we're going to look at main terms. The main term, as I said earlier, when you have a diagnosis, you may have 1 word, maybe 2 words, it could be 6 or 7 words. But out of those, you have a main term that is the actual disease itself that you're going to look up. So if I give you like chronic gastritis, what would we look it up under? Well, we would look it under gastritis because that's the actual condition and disease. Chronic just describes it. Okay. Then you have non-essential modifiers. These are supplementary words. So again, chronic gastritis. Gastritis is your main term. Supplementary is chronic. So when I look at my G's, I can go gastritis, then I hold my place and go see if I can find a chronic underneath the gastritis. And sometimes you can, sometimes you can't. If you look at that example, it gives you the main terms and the subterms. It gives you deformity, and this is how it's going to look like. It's going to be tabbed in, and so you'll have aortic deformity. And then under aortic it may be the aortic arch, or it could just be somewhere else in the aorta. Okay, so if we have an acquired aortic arch deformity, then that's how we look at it. It's tabbed underneath, and so you have to really be careful when you look at it. Subterms, these are also called essential modifiers, and these qualify the main term by listing, the site that it's located. So I think it gives you an example, myromelia in the lower limb, and then it goes even further and gives you more qualifiers and qualifying words. You can come in. Okay, sorry about the interruption. But anyway, you have your subterms and then your qualifying terms too that can help you. So we'll get a lot of practice with that, and it may look difficult right now, but it's really not extremely difficult at all. Let's see. If it's continued on to the next page, you'll see that main term again at the top in like a little dash, and it'll say continued. And you can, when I pass out the books, you can have one for yourself and look at it and, see all the stuff that we're talking about here. Okay, if we have a subterm or an essential or non-essential modifier, anything that can help us increase the number of digits and the level of specification, the better. So like I said earlier, we always want to do the highest specificity. Okay, so using the index diseases, step 1, you want to locate the main term. And so it gives you irritability of the bladder. Well, what's the actual disease? Irritability. And then the next word we would look under is bladder, or we may say irritable. It may not give you irritability. It may say be irritable. And a lot of times, even though it's our main term, we may have to, you know, tweak it a little bit. Impacted feces. Well, what's the problem? Is feces the problem, or is the impaction the problem? The impaction is the problem. Comminuted fracture, left radius. What's the condition? It's a fracture. What type of fracture? Comminuted. Qualifier, radius. Then second qualifier, the left radius. You see what I'm saying there? Upper respiratory infection. What's going on with the patient? They have an infection. Okay, so that's your main term. Step 2, the phrase, if you see C condition, that's found a lot after these terms, it basically doesn't, I really give you a hint, if it tells you ever to see condition, if you go to condition, it's hardly ever there. You have to kind of play around again. So if the patient, or if the physician gives you myocardial infarction, and you look up myocardial, it's not going to be there, because myocardial just tells you where the infarction is, but the infarction is actually the condition. So you would look it under infarction. Okay, table 6A1 gives you like a list of different difficult words to find, okay, and where to find it. So if we couldn't you know, find it somewhere, then we could say, okay, should we go to abnormality? Should we go to aftercare? Should we do observation? You know, what should we do? So these may help you out a little bit. Step 3, when the condition is listed is not found, you want to locate the main term, such as syndrome, disease, disorder, derangement, abnormal. That's what you want to go for. Let's see, the coding conventions on page 161. You do need to know these. Coding conventions are basically just a bunch of rules, and we're going to look at these, and you need to look over them yourself. If we have codes that are in slanted brackets, this means that they're always listed as secondary codes, and they can never be listed as primary codes, okay? So you may have like 123.4, and then in these brackets that are slanted beside it, you may have 185.3. Then we have to list them in that order. The bracket ones that are slanted can never be the primary code. Eponyms. These are diseases or procedures named for an individual, like Kaposi sarcoma or Barlow syndrome. So you want to see, basically you want to go to syndrome. You don't want to go to the person's name. Essential modifiers are subterms, and we've already talked about that. NEC, you may see that, and it says not elsewhere classified. This means that basically you're going to have to get more information to find the code. Now you can give a person an NEC code, but it basically means that you can't really go any more specific than that code. Let's see, non-essential modifiers are subterms that are enclosed in parentheses, and it gives you an example. Like we may have a pseudomeningeocele, but in parentheses it could be cerebral, it could be infective, and it basically means as long as one of those words are in there that you need, then we can use that code. Okay. Flip on over. Notes. We will have note sections, like under hypertension. It'll give you like a note 0, 1, 2, 3, and 4, and to add and basically it's a 5th digit note. Okay. So an example, it gives you spontaneous breech delivery, and we assign 652.21. But then it says note, and it says use a 5th digit for the codes between 640 to 649, and 651 to 676. Well, does our code 652 follow in between? Yes, and so we have to figure out what 5th digit we're going to use there. If we have something that says C, like if you go to infarction and you're trying to find myocardial and it says C chest pain or something like that, then it's like a cross-reference telling you to see something else. C also is kind of the same thing. It may give you additional information if you go to the C also. So you may get your code, but you may find a higher specificity if you follow what it asks you to follow. And then C also condition is basically the same thing. It gives an example of late pregnancy. Well, pregnancy you would think is our main code there. Well, it says the main term is late, directs the coder to C also condition, but actually late is not really your main term there. I think the book may have boo-boo pregnancy is, but if you go to pregnancy, you're not going to find late pregnancy more than likely. So basically you would go to it says late, C also condition, effective, C also condition, and then you have to try to figure out what other term it could be under. Alright, the tabular list of diseases, page 163. Like I said, after you look up the code in the index of diseases, you have to verify the code in the tabular list, because a lot of times you'll get used to flipping over there, it's the same, but that one time that you don't look, it's going to tell you to use a 5th digit or something. So to make sure, you always use the tabular list to verify. V codes are expressed as a 3-character alphanumeric code, so it'll be like V12 or V12.4. That's how it's going to look like. The same thing with E codes. E codes may be all 5-digit codes without a decimal in between it, but you'll have E and then like 3 other numbers. Okay, that goes with it. And then, like I said before, you never use E codes as your first diagnosis. Then we have chapters in the tabular list. The chapters, and again, you do not have to memorize those, but you can look at them to say, okay, well, if I'm looking for a condition and it's in the neuromuscular system, then I know that that is in this chapter, and so I'm going to go to this page to look for it. That's really the only thing you can really use in the chapter, like the table of contents, basically. If you go in the chapters and you're verifying your code and you see 123.4, but it says excludes, and then it gives you basically the diagnosis that you thought was good, then you cannot use it. You have to start from scratch, go back to the index to diseases, and start again. Major topic headings, these are printed in bold uppercase letters, and then it has like a bunch of codes underneath it. And if you look on page 164, it gives you the chapter heading, then it'll give you any exclusions, then it'll give you little notes about how to do it, and then it'll go into subheadings and stuff after that. So that's how it's listed. V codes and E codes are in the tabular section, but they're at the end of the tabular section. Okay, so V codes will come after your numerical order list, and then E codes will come after your V codes. Then you have your categories. These are topics that are divided into 3-digit categories, and they're printed in boldface letters. Like you have V70 is a general medical examination. Okay, then you have V70.1, V70.2, V70.3, etc., etc. Okay, so those are your categories, and then your subcategories would be that V70.1, V70.2. Those are considered your subcategories, and they're indented underneath the categories. Then you have subclassifications. Those are indented under the subcategories, so it can go further and further and further. So for subcategory, you have V70.2, and then your subclassification may be V70.21, V70.22, V70.23. So that's how it's going to be listed. We'll do those examples Wednesday. So let's look at page 167 using the tabular list of diseases. Step 1 is you're going to locate the first possible code number. Step 2, locate the code number in the tabular list of diseases and review the description and review any exclusions. If the condition is excluded, then we've got to start over. Step 3, assign any required 4th or 5th digits. Step 4, check to be sure the code number is appropriate for the age and gender of the patient. Like, we don't want to give somebody testicular cancer if it's a female, okay? Step 5, return back to the index of diseases for other code selections if you can't find a proper code. And then you're going to enter your final code. So basically, you're going to start in index of diseases, find alphabetically, find your diagnosis, look to the left of it, there's the code, keep the code, mental note of the code, flip to the tabular, look in numerical order, and make sure it's correct. Let's look at page 168, 169. These are coding conventions for the tabular list. So these are the things you're going to see in the tabular list. If you see and, this is interpreted as and or, okay? And so that means that acute bronchitis and bronchiolitis, if they have both of them, then you can give that code. If they only have one of them, like acute bronchitis, you can only use 466.0. If we have a bold type, like acute and subacute endocarditis, all right, then underneath that 421.0, the subcategory, I think is what it's called, we have acute and subacute bacterial endocarditis, okay. Then we have stuff that's in braces, like we have the example, diseases of the vocal cords, and you have like 6 or 7 diseases, and then it's giving you like a little synopsis saying that this all is included in the vocal cords, so you'll know. If things are in brackets, this means it's like alternate wording or to better explain it. And so you have pneumonia due to the Haemophilus influenzae, and it's also called H. influenzae too. Or it's all, it may even have Hib in the brackets, and that just means that that's included with it as well. Code the first underlying disease. If it tells you that, if you have tectonic cataract and it says code the first underlying disease, then you have to go what caused the cataract. You got to code that first, and then you can code the tectonic cataract. If you have a colon, this means it's used after incomplete term, and it's followed by modifiers. So we have V72.0, chronic rhinitis. Then we have ozena, and then we have rhinitis, colon. And what kind of rhinitis? Is it NOS? Is it atrophic? Is it granulomatosis? Or granulomatous, excuse me, hypertrophic? Is it obstructive, purulent? What is it? So it gives you a whole list of things that's included within that code. If we have excludes, that kind of means the same thing. If we're looking at diabetes mellitus and it says it excludes gestational diabetes, then we cannot use that 250 code. We have to use 648.8. Format is the way all additional terms are indented below each term. So if we have internal hemorrhoids with other complications, and then it says internal hemorrhoids, are they bleeding, are they prolapsed, are they strangulated, are they ulcerated? That's what formatting means. Everything's tabbed under each other, so you can easily follow. And then 4th or 5th digits, these are indicated by a little note, okay? In the tabular list you'll see 0, 1, 2, 3 or 0 through 5, and it'll say the following 5th digit classification is for use for category 250. And so if you have 250.11 that you've looked up, then you know we need to go back and make sure that that 5th digit, which is 1, is correct. And if it's not juvenile diabetes, then we've messed something up, we've coded incorrectly. And a lot of these will make more sense when we actually start coding. Then we have includes. So acquired hypothyroidism includes. That means it includes any of those. It doesn't mean that it includes every single thing, but any of those are fine. NOS is not otherwise specified. Okay. It just means that it's unspecified. Okay, and it doesn't mean that you have to go anywhere else. It just means that that's about the highest you can go. Notes. These are any kind of little extras that give you extra information. Parentheses. These are they enclose supplementary words. So if we have here non-toxic multinodular goiter, then it says in parentheses it says non-toxic. That's just considered a modifier. If we have use additional code, that means that we need a second code. So if we have emphysema, and then underneath it says use additional code to identify if it's infectious, then we have to use the emphysema code 510 and then another code along with it. And then with, you have to be very careful. If I have varicose veins of the lower extremities, then all I'm going to use is 454. If I have varicose veins of the lower extremities with an ulcer, then I'm going to use 454.0. And you can see that's tabbed in a little bit. So you have to be very careful with that. Alright, we're going to skip the I-79 procedures because I told you that volume 3 we're not going to really use too much. But I do want you to look on page 172. We're going to talk about procedures for just a second, because I want you to remember the difference between a principal and a secondary procedure. And it's basically just like your diagnosis. If I'm coming in to have a knee replacement, that's my principal procedure. I may figure out that during the surgery I'm going to have a bone fixed somewhere that's in close proximity, and that would be considered your secondary procedure. So that's really all I want you to know with the volume 3. We're going to skip the rest of that page and go on over to page 173, and we're going to talk about the hypertension table. This is in the index to diseases, except it's got its own little table, and if you look at figure 6A6 and 6A7, it kind of shows you how it looks. But we need to know all these names, and so you need to know the difference in these. Malignant hypertension, this means that it's severe form, okay, that it's chronic and it's severe, and it's caused, a lot of damage. Benign means it's controlled. Unspecified means that, we don't really know. Maybe they were just diagnosed with it. So, and that would be unspecified. So make sure you know the difference in those. The table of neoplasms, that's on page 175, and it looks very much the same, except instead of going to the H's in the index to diseases, you're going to go to the N's, and you'll find that neoplasm table. Neoplasms means new growth, okay, and there's all types of different other names that are associated with this that we have to know, and if we don't know them, then we can't properly code it. If we do have something, if the doctor says like a lesion or a lump or something like that, we cannot go to the neoplasm table. We have to code that in the L's for lesion and lump. Okay. And one other thing, if we think the patient has a basal cell carcinoma but we haven't gotten the test results back, we cannot diagnose them with basal cell carcinoma. We have to diagnose them with abnormal mole or abnormal lesion, something like that. Okay, and it gives you benign lesions are called mass, they're called cyst, dysplasia, polyp, adenosis. All of those are signs of stuff that you can use when you're actually doing the coding. Alright, so these are the terms that you're going to have to know that are all in the neoplasm table. Primary malignancy, that means it's cancerous, and that was the first site of your cancer. Like you hear people that have breast cancer and it metastasizes to their brain. Well, breast cancer is the primary site, then the brain would be your secondary site. Okay, so primary malignancy is mean where did it originate. Then we have your secondary malignancy. That would be if it has metastasized where did it go? So if I had breast cancer that metastasized to the brain, the breast cancer would be your first diagnosis, and then the brain would be considered under secondary malignancy. Then we have carcinoma in situ. That means that it is in position and not moving anywhere. Okay, it's localized. Then we have benign, and this is non-cancerous. Then we have uncertain behavior. This is something, you know, that we don't know what it's going to do yet, and we can't really predict anything. Then we have unspecified nature. This means that we've identified that there's a growth, but we don't have any kind of other prognosis with it, basically. So anyway, you'll really need to know these different subcategories. All right. So if you look on figure 6A7, excuse me. Let's look at abdomen. If you have an abdominal neoplasm, well, if it's primary, we would use 195.2. If it's secondary, we'd use 198.89. If it's in situ, we'd use 234.8, etc., etc. So that's how you read it. Okay. Let's see. If we have, look on page 176. If we have a tracheal carcinoma in situ, we're going to go to the neoplasm table. Then we're going to look under trachea, and then if it's a carcinoma in situ, it is malignant, and then we look under the in situ and get the code. If the doctor says benign breast tumor, male, we're going to go to the neoplasm table. We're going to go to breast because it's by location. Then we're going to go to male, and then we go over to get under the benign. If we have Cowper's gland tumor, uncertain behavior, we're going to look under Cowper's gland, under the C's, which is in the neoplasm table. So basically where I'm going is all of these you're going to look in the neoplasm table. Okay. Then example 2, if it's not found in the neoplasm table, you actually have to go in the regular index to disease, like non-Hodgkin's lymphoma. We have to go to the index to disease under the L's for lymphoma, and then look under lymphoma for non-Hodgkin's. Adrenal adenolymphoma. If we can't find it in the neoplasm table, we have to go to index to diseases under the L's for lymphoma, and then under the A's for adenolymphoma, and then look under adrenal. So that's how you do it. And again, with these, after you find your code, you still have to go to the tabular to verify. Okay, look on page 177, primary malignancies. Usually if it doesn't say, you know, it's primary, we assume that it's primary. So if it says metastatic from a site, so if we have metastatic cancer, brain cancer from the ovaries, then the ovaries are the primary site, the brain cancer is the secondary. It's spread from a site, so you have from, that's your key word. Primary neoplasm malignancy for no specific classification, we assume it's primary. A recurrent tumor, so it's still primary, except it's recurring in the same place. Then secondary malignancies, we have the word metastatic or metastasized, and that means it's spread. Okay, so if we have something that says it's metastatic from the ovaries to, you know, something else, then we have to do primary first, and then the secondary would be where it metastasized to. Okay, let's see, let's look on page 179. If the anatomic site is not documented, we have to go to, we have to assign unspecified site for the primary and secondary. If we're using, you know, metastatic cancer, we have to do primary, unspecified, secondary, unspecified. If we have a primary malignant site that's no longer present, guess what? We still have to code it, but we're going to code it differently. So you don't assign the code for primary of unspecified site. We're going to classify the previous primary site by a V code because we have a history of a carcinoma or sarcoma, whatever it is. And then we're going to do your neoplasm code. I'm sorry, it would just be the V code. Now if it recurred to somewhere else, then we would also code the neoplasm. If we have overlapping sites, we're going to still, we want to go with your first initial site and then the second site. A re-excision of tumors, that means we had to go back and, the pathology report may have said you need to go back and re-excise this to make sure that, we get more of the cancer. So that's what that re-excision means. And then we have to code it as such. We have to say, the patient is in for a re-excision, but they've had, a skin cancer or basal cell carcinoma. So that's how you do that. Okay, so it gives you a coding tip. You want to read all the notes in the tables. You want to never assign a code directly from the index diseases. You want to check it in the tabular. Be certain you're submitting codes that represent the current status of the neoplasm. Assign a neoplasm code if the tumor has been excised and the patient is still undergoing radiation. Okay, so I may have taken my breast tumor out, but I'm still being treated for it. Assign a V code if the tumor is no longer present. A classification stated on a pathology report overrides the morphology stated in the index to disease. Alright, going on to the table of drugs and chemicals. We still got quite a ways to go. The table of drugs and chemicals, this is where you go if somebody does, if they, try to kill themselves or they accidentally ingest something, you're going to go to the table of drugs and chemicals. And these also have terms that you need to know. The first thing you need to know is there's always going to be two codes when you're dealing with drugs and chemicals. The poisoning code is the first one, and then what caused the poisoning is the second. Okay? So we have all different things. We have the adverse effect or adverse reaction is something that you're taking it for a therapeutic reason. However, you had a bad reaction to it. Okay? Then let's see. Poisonings. I already told you poisonings is going to be your first code. It's going to give you a code, and then you have to go to the reason behind it. So you have poisoning. Then you have if it's an accidental poisoning is a therapeutic use, meaning that the medication was prescribed or we're taking it for symptoms. Was it a suicide attempt? Was it an assault by someone else? Or is it undetermined? But remember, all of those are E-codes. So we have to do the poisoning code. So if you look at that first one, if we had an accidental poisoning of propanol, I'm going to look at propanol 1. Let's say that I have to use 980.3, and then it was an accident, so I'm going to say the second code would be E860.4, and that's how you would code it. Alrighty, let's see, supplementary classifications, your V codes. We've already talked about this. These are for services or factual reporting, okay? And they're going to be anything that will influence the patient's health status. Alright, so you have an example of a family history of something, a 6-week postpartum checkup. So those are the things that you're going to look at. You can expect to have a V code. Now, these are not looked up in any different kind of way. They're looked up just the same, except they have a V in front of it. Let's see, table 6A, 5A, you do not have to know, just, completely ignore it. It just kind of tells you the little categories, but you do not have to know it. So let's look at bottom of page 187. Some of the main terms where you know that you pretty much know that it's going to be a V code. You may have admission, aftercare, contact, closure, observation, pregnancy, prophylactic, removal. All of those are signs that it's going to be a V code, pretty much. And you do not have to memorize all of those words by any means, but those are just an FYI, some terms to help you out. Okay, coding special disorders. Let's look at HIV and AIDS. first of all, anytime you test the patient for HIV and AIDS, they must sign a form saying that they agree to be tested, okay? Otherwise, then you can get in trouble. But 042 is usually the HIV and AIDS diagnosis code. Then it gives you all these different codes to assign, you know, if they have HIV but they're not symptomatic, if they HIV and has just gone to AIDS, and you do not have to memorize all of those codes. The main thing I wanted you to know there is that if you are even testing a patient for HIV and AIDS, you must have them sign a document saying that they agree to be tested. Okay, fractured cases. Usually it's going to ask you if it's an open fracture or a closed fracture. Closed fracture means it's not coming through the skin. An open fracture means that the skin is open or the bone's coming through the skin. If it doesn't say, then in most cases it's closed. But you do have to know the difference between closed and open. So if you look at table 6A6, common words that are dealing with closed fractures are comminuted, linear, spiral, impacted, simple, green stick, compressed. Those all mean that they're closed. And again, you do not have to memorize these words, but these are things that will help you know if it's open or closed. And then your open terms, compound is always used. If you hear compound, that means it's open fracture. A missile fracture, meaning that something came through and entered the skin and broke the bone, or the bone came through and flew out. A puncture fracture, a fracture with a foreign body. Infected fracture. Well, you cannot have an infection of the bone unless you have some kind of open wound. So all those mean open. And when, if we have like a tibial fracture, then in the index to diseases, you go to fracture. If I say a comminuted tibial fracture, that tells you it's closed. So under fracture, you're going to go to closed, and then under closed, you'll find the body part, tibia. And whatever's by tibia is the code that you look for, the code that you want. You can verify it in the tabular listing. Okay, late effects. These are not fun to do by any means. They're harder. But a late effect is considered like a residual effect, something that happens later. Like I may be coming in because I have arthritis in my knee from an old knee fracture I had 10 years ago. So if I come in and the doctor just says right knee arthritis, but that's all they put. If I need an MRI or something, I'm probably not going to get approved for it. But if I put arthritis today, and then I code because it's a late effect of a fracture from 10 years ago, then I'm more likely to get coverage. So that's what the late effect is. And pretty much you're going to have two codes for this. Sometimes we'll just use one code, but you're usually going to use two codes. So common late effect terms, and again, you do not have to memorize these. These are just to help you. Fracture, if we have an original fracture, then the late effect may be the malunion of two bones. They don't grow back together. If we have a CVA, a late effect may be that we may have hemiplegia. If we have a third-degree burn, a late effect may be deep scarring. So we're going to code fracture, all right, and then we're going to code late effect malunion. So your first code would be fracture, then you would go to the L's for late effect, and then you would find malunion and code it like that. Page 190 on burns. Burns require two codes, one for the site and the degree, and then a second for the percentage of body surface. Okay, so if I have a second degree burn of the hand, I can assign that code, and you'll go to B for burn, and then you'll scroll all the way down to you see second degree, and then you'll go to the body site, assign the code, and then I'm going to look at this little chart right here, and I'll give that to you on the test. Well, how much is the hand? It says, or arm, each arm is 9%. So then I have to code the percentage dealt with that, the body surface area. So you have two codes for that. Then we have congenital versus perinatal conditions. Congenital means that you are, it's diagnosed at birth, or it's diagnosed, shortly after. Okay. Then perinatal means that it's diagnosed, before birth, or within the perinatal period. The first 28 days of life is considered perinatal. So perinatal period is occurs before birth or 28 days right after birth. All right. So you need to remember the difference in those, and you're going to code those the same way. But I just want you to know the terms. Then we have E-codes. These are extremely hard to deal with, and we're not going to talk about them in this lecture, but I just want you to know, remember that you go to the index to disease, and then in the very back you'll find the E-codes. They have their own little section, and you'll see weird stuff. Patient has a bone infection from being bit by a shark because he fell out of a speedboat. That's the kind of specific stuff that's in there. So that's what an E-code is. It's external cause. Alrighty, I think we'll stop right there, and I've kind of given you an introduction. You need to look at this lecture if you need to, and you probably will, and then we'll practice. We'll go in order and practice when we get to class.